hope that in talking about this, that you get some understanding of how the decisions are made from the neurosurgeon standpoint as to what it is that we would do for you, depending on what your complaint is and where you're hurting and when you hurt and so on and so forth. And I'll sort of dispel one of the myths before we start and say that the MRI is only one piece of information in the decision making. That many patients come see me and say, well, the MRI says I have a pinched nerve, and undoubtedly true. And as you get older, you'll find that the number of pinched nerves that are seen in the pictures of your spine will go up very reliably and very predictably. And that in and of itself doesn't tell us to do anything to your spine. So that somebody who has a pinched nerve in their spine who has no symptoms whatsoever doesn't get an operation done, because having an operation done is no fun, and you don't want it unless you need it to be done. So that the MRI is a small piece of information in a much bigger picture, and that without speaking to a patient about it and talking to them about where they hurt, when they hurt, how they hurt, what things make it better, what things make it worse, the MRI winds up being very unimportant in the decision. The MRI tells us what we can do, but the patient tells you what you should do or should not do, as the case may be. So this is a picture of the lumbar spine. I've confined myself to the lumbar spine for the purposes of this conversation in the greater Tucson area, where there are many people in their 60s, 70s, 80s. I saw a 90-year-old this morning. The lumbar spine is an area of great discomfort for many people. I would say probably more than half of the surgeries that I do on people wind up being in the lumbar spine, just simply because it's such an area of problem for people. What you see is an area of spinal stenosis on the MRI. As we age, I try to liken the lumbar spine kind of to a machine, or to an automobile, if you will. That the parts were a well-oiled machine at some point early in its existence, and as time and wear and tear accumulate over the course of time, the parts don't fit together quite the way they once did, and you develop problems really because of abnormal motion that exists. And it's abnormal compared to the way it was when you were 18 years old, but it's not abnormal in the course of the normal aging process. So that there are a lot of big terms that we can use to describe what is wrong with people's spines as they age. Spinal stenosis is sort of a catch-all term, which means that the nerves running down the long tunnel of your back are being pinched. That the tunnel that your nerves run down is narrowed, and that's all it means. Why it's narrowed? It can be narrowed for several different reasons. Usually, it's not just one reason. It's more than one contributing to the overall condition where things are narrowed. The other things, whether it's a disc protrusion or a spondylolisthesis or ligamentum hypertrophy or facet hypertrophy, these are all big, long terms that aren't worth anyone knowing about other than the surgeon. But the specifics of these determine what the treatment is. So that when you hear somebody say, well, I had surgery for spinal stenosis, that could mean 100 different things, and that when you see a scar on somebody's lower back, I had low back surgery, and this is what they did for me, may be totally appropriate for one person and absolutely inappropriate for another person, and that without all of the details, that none of it can be universally applied to a general population. So when people get pain, it is usually a combination. Certainly in the aging spine, the discs degenerate, the ligaments thicken, bone spurs develop, and any and all of these things can contribute to giving somebody pain in their back or down their legs. And I'll add also, it isn't always, in a pure spinal stenosis case, it isn't always pain. Some people will come to see you because their legs just get tired when they walk, or their balance seems off. And they'll give you a history of I can walk for a variable number of feet, 100 feet, 20 feet, half a mile, and then I have to sit down because my legs are tired. But if I go to the store and lean forward on the grocery cart, I can walk for all day, and it doesn't bother me at all. So that it isn't always pain that does it. And the value of surgery in treating this, it does not depend on whether it's painful or not painful. It depends on whether the nerves are being pinched and the symptoms are a consequence of that or not. So I've talked about lumbar spinal stenosis. Again, I would say at least probably 3/4 of the patients that I see have read their reports or been provided a copy of the report, and they'll come in with terms underlined, or they'll have been on the internet and looked up different terms that they would like to understand what they mean. I think it's good for people to be interested in their own health. I think that you will probably drive yourself crazy trying to understand all of the different nuances to the language that is being used, and that, again, for the purposes of a patient understanding their problems, the terminology is not especially helpful. Understanding what is going on in your body, I think, can be helpful, and it rarely can be dissected down to just a pinched nerve or a single entity. Many people would like to know what their diagnosis is, and I could probably make up 100 diagnoses for every patient that I see. It doesn't really move us forward to give it a label. But spinal stenosis, as I said, is the tunnel. The tunnel that your nerves go down, and what you're looking at is a tunnel that starts at your head and goes all the way down to your behind. And that tunnel will narrow predictably in places, largely in the lower back, also in the neck, where there's areas of motion. So that you bend at the waist, it's your lower back that's doing the motion. You bend in your neck, it's the neck doing the motion, and that's the areas where we develop stenosis. On the right there, you can see the narrowing that's surrounding the nerves. And what it doesn't show, the next one does now. What it doesn't show, I tell patients in the office that the spinal cord is like the trunk of a tree, and that the branches of that tree go off for the purposes of our lower back into our legs, and that those branches also go through tunnels. So the spinal cord, the tree trunk, goes through a tunnel, and the branches go off into the legs, go through a tunnel. And where they go in the leg, which includes the buttock and the hamstring and the thigh and the leg and the foot, different nerves go to different places. You can have narrowing around the trunk of the tree, you can have narrowing around the branches of the tree, you can have narrowing around both. I would say more often than not it's both to a certain amount. And again, the decision making from a surgeon is, well, what is being pinched? Is it the tree trunk? Is it the branches? Is it both? And then the secondary question is, what's doing the pinching? How do I unpinch it? That tunnel in the lower back is made up mostly of ligament. There's a very thick ligament that runs in this space here behind the spinal cord, that is to your posterior of the spinal cord. This is what a disc looks like in a 14-year-old, but in most of us, it is bulged a bit out of place, and also contributes from the other direction to the narrowing of that tunnel. This also doesn't show, there are joints in our back. This doesn't really show it, but they're joints just the way that a hip and a knee and an ankle and a finger is a joint, and the joints in your back are susceptible to all of the same maladies of every other joint in your body. They get arthritis, they get inflamed. I will usually ask patients or observe in patients that they get the big knobby fingers and bone spurs in their hands. That problem happens in our lower back too, but it's way deep down inside of us where you can't see it, you can't feel it, and that's why it's, I think, intuitively difficult for people to think about. But those joints will become overgrown just like the finger joints do, and those also can contribute. So you can have disc bulges, you can have joint, what we call arthropathy, joint overgrowth. You can have thickened ligament. There are yet more. There's misalignment of bone that can contribute to the narrowing. And so that happens to be the ligament there, but again, this is not a comprehensive anatomic picture of what things look like. Stenosis, I made reference a minute ago about what somebody typically will present with. I think it is very much related to whether it is the trunk being pinched, the branches being pinched, or both. And it is usually not one or the other. It is much more often some combination of the two. In a pure spinal stenosis case, this pattern of leg weakness, occasionally leg pain, occasionally both, balance trouble that will go away when sitting. I mean, the patient will say, yeah, I can go to the store and I walk for 15 minutes and my legs get so tired, I'm walking stooped over, and I sit down and after a minute or two I feel fine and I get up and I do it again. And the pattern repeats itself over and over again. Or the patient that wants to lean forward on the grocery cart and can go with virtually unlimited time. So these are some of the symptoms. I mean, if I can get a patient to tell me that they can walk forever with the grocery cart but can't walk hardly at all without it, it almost is diagnostic of the problem. There is a concern, and I see it's probably an over-concern of people that have an insufficiency of blood flow in their legs. And some patients I will see will have been sent, and their primary care doctor will have ordered a study of the arteries of the leg to see if the blood flow adequate or not. There are people in which we have that concern. I think people who are long-term smokers are at risk for developing peripheral vascular disease. People that have reason to have vascular occlusion, long-term smokers, high cholesterol, other areas, so if you've had heart attacks, you've had strokes before, that you know somebody. And in people like that, the expectation is that if you are having pain in your legs when you use your legs, that can be an insufficiency of blood flow rather than being some problem with your nerves. One of the ways we use to try to understand that is to have somebody ride on a bicycle, so that if you're in the seated position and using your legs, if it is your back, that seated position ought to alleviate the back problems and your legs shouldn't hurt. But if it is a blood flow problem to your legs and you're pedaling a bicycle, you should get every bit as much pain in that position as you would when you're up walking or running. So this pattern of leg pain, pins and needles, weakness, particularly relieved with various positions. Another common diagnostic problem we see with people that have peripheral neuropathy. So diabetics most commonly, but a lot of people will have a peripheral neuropathy that has no explanation for it whatsoever. It's one of the unfortunate things that can happen to us as we age, so that it isn't always spinal stenosis, but we do look for other causes of the pins and needles in people. The inclusion of back pain, in addition to leg pain, again, these are important for the decisions of the surgeon as to what to do if we're doing an operation on you. The MRI doesn't tell us anything. We have to talk to you in order to understand what it is that we can do to help. So the treatment options, which may be why many of you came, it's sort of three general rules, three general options. Decompression only surgery means we say your nerves are pinched, let's go unpinch them, and that'll be that. There's a decompression with we call intralaminar stabilization with this device. It's called Coflex, and then fusion. And again, I think the title of the talk focuses inherently more about the intralaminar stabilization, the Coflex, And I think it's a great device. I think that people who've not had surgery before wouldn't know how great a device it is until they saw what the alternatives to it were. And so if we look at Coflex in the context of putting nothing in there after decompression, which I've done many dozens of times, or fusing somebody, which I've also done many times, I think the Coflex winds up being a very attractive offer that's not available to every patient. It's not something that we can empirically just say you're going to get this done, but it is an attractive option for people if we are deciding to do surgery. So decompression, this picture shows us sort of a general idea of what this is. We remove the bone on the back of the spine and make the hole, the tunnel, as I said, that is around the trunk of the tree. We make the tunnel bigger, and that's it. It is very commonly done. You likely see things like laminectomy on TV, or when you Google it, laminectomy is something that comes up quite frequently. It's a very common operation, been around for a very long time. It is a very successful operation. The reason anybody thought to go further than just going and unpinching the nerves is the downstream consequences, or potential downstream consequences of unpinching nerves. So that the way I look at it is that you got built with a number of parts, and for us to go in there and remove some of these parts, we have to expect that there is a physical cost to that, to your body. So that these things, what they're showing is removal of the lamina. There are also ligaments that are removed. There is a destabilizing effect of this, and sometimes that destabilizing effect amounts to nothing, and sometimes the destabilizing effect becomes very important in the long term. And the more years we expect you to be alive beyond the time of the operation, the more important it is. So the laminectomy is a very successful operation. It is appropriate for many people that we see, but it does have the potential to destabilize the spine, and so we have, over time, as surgeons, tried to come up with alternatives to just destabilizing things, and we've come up with some good options, I think. This is the Coflex picture. Basically, what we do when we insert a Coflex is, at least as I would explain it to patients, is we give back the strength we've taken away. I mean, the unpinching of the nerves winds up being identical to what we would do as if we were putting nothing back in there, but we do put something back in there, and it's in an attempt to try to compensate for the weakness that we have imparted to you by virtue of unpinching your nerves. Maybe I should have put it after the fusion slides, but it's outstanding. Its efficacy, it's how well it makes you feel is comparable to fusion, which is a very comprehensive treatment of the problem. But it isn't the fusion, so that your hospital stay, your blood loss, your operative time, the medications we can use afterwards are all it's a benefit to use Coflex versus a fusion, and it does just as well as the fusion. I think fusion it gets a pretty bad rap. I don't know if this is online or just in public discourse. Fusions is a bad word for many, and probably is overdone in the United States in general. That is, it's a common operation. It's fairly invasive relative to the other things I've mentioned. It's quite invasive. There's a lot of aftermath of doing fusions that our instruction on what you are allowed to do. We don't want you bending. We don't want you twisting for months. We're harping on you about your activities. You can't do your housework. You make your husband do your housework for you. It's a common complaint that people are unhappy with the amount of restriction. Again, it's sort of this. If you didn't know the restrictions of fusion, you wouldn't find the benefit of Coflex. Another would be in fusion, you can't use anti-inflammatory medications afterwards because the chemical process of fusion in the human body is inflammation. You can't turn one off without turning the other off. And so we will prohibit you from using anti-inflammatory medications after fusion. But with Coflex, you don't have that prohibition because we're not fusing the bones together. But that said, there is a time and a place for fusion, and I think that there are a lot of patients who come in with the idea that they don't want a fusion done as sort of the starting point of the conversation, and it doesn't work out so well. I mean, to decide you're not going to have the right operation is usually a bad move, or I would say it a different way, to choose to do a small operation because it's small and not because it's the right operation is a recipe for a bad outcome. That sometimes fusion is the appropriate operation to be done on people. I think as surgeons you gauge the ability of a patient to tolerate such an operation, and you do what is appropriate for the patient, not do the small surgery because it's small. Coflex is also used in conjunction with fusion, albeit not in the thoracic spine. But some of I think my earliest patients were people that at one point in my life I would have had to have done 2 or 3 levels of fusion on, who instead I will do 1 level of fusion on and put 1 or 2 levels of Coflex in with it, so that the success rate of fusion can be measured in many different ways, but one of them is actually fusing. So when we're fusing people's bones together, the fusion doesn't happen in the operating room, the fusion happens in the months after the operation. And the more levels you do, the less likely you are to be 100% successful. I mean, if there's a 5% risk of each level not fusing, then multiply your risk times 3 if you're doing a 3-level fusion. But with Coflex, there are many patients I've seen, many patients that I've seen and operated on who didn't need 3 levels fused, but they needed something done to 2 of those levels. And so you fused 1 and put a Coflex in 1 or 2 of the others. And all of a sudden you're only having to pay attention to whether 1 level fused and not 3 levels fusing. And to me that is, it's not, I don't think the company does a very good job of advertising it that way, but I think it is one of the best assets of the product is that you can use it in conjunction with the fusion, and it does. I mean, it gives people the relief that the fusion part would also provide without the risk. The motion preservation. So I use the term fusion. I'll go back and say that when we're fusing, it means we're growing 1 bone out of 2. That the space that is currently occupied by a disc is removed. We put something in between, often a titanium, a piece of titanium, and that piece of titanium is implanted with material that will allow 2 bones to turn into 1 bone. And that transformation takes place over the course of months after the operation. With Coflex, we're not doing that. We don't desire to do that. We're preserving the motion, and the idea is that if you put one of those in there, that the levels immediately above or below the fusion are not stressed in the way that they are if you fuse the level. So it's a motion preserving device, which is important. When we fuse people will always ask me, well, am I still going to be able to bend over and tie my shoes or do things? And the answer is yeah. When we fuse you at a couple of levels, 2 or 3 levels, you can still do those things. The trouble is that it's far fewer bones that are doing the work that have previously been done by the ones that were fused. And as a result, they do 130% of their job or 150% of their job, and you multiply that by years, and you have a risk at about 2% per year of needing another operation simply because you had the fusion done. And with Coflex, again, that's one of the incentives for its having been invented, is that when you preserve motion in the levels you've been treating, you don't displace that stress to the other levels of the back, and so not apt to need to have another operation done down the road.